Welcome to the lecture on suppositories. We will start the lecture with a definition. Suppositories are solid bodies of differing shapes and weights depending on the intended route of administration. It is precisely because suppositories can be inserted for use by various routes, including rectal, vaginal, or even urethral, that they come in a variety of sizes and shapes so as to better fit the intended orifice. Suppositories can be used for two main purposes. The first is to act locally as a protective around the tissue where it is inserted. On the other hand, we may want the suppository to act simply as a vehicle or carrier of an active drug that we want absorbed at the site of insertion but distributed systemically to produce an effect throughout the entire body. Depending on what we want the suppository to do, we can formulate it to either melt at body temperature or dissolve in body fluids. It is the suppository base chosen as part of the formulation which will determine whether the suppository melts or dissolves. Therefore, the intended route of the suppository will dictate its size and shape, but its intended action, meaning either to melt or dissolve, will dictate the type of base to use in the formulation. To understand why a suppository is formulated a certain way, you must understand why it has been prescribed and what the prescriber intends to accomplish by having the patient use it. Recall that suppositories are used when either a local effect is needed in the rectum or vagina or urethra, or when systemic absorption of the drug is desired. For example, the local effects of a drug administered rectally can include soothing of inflamed hemorrhoidal tissue or promoting bowel evacuation to treat constipation. On the other hand, rectal administration can allow systemic absorption of an active ingredient to produce an effect throughout the body in order to treat a variety of conditions such as nausea, anxiety, or migraine headaches. Additionally, a drug like progesterone is often compounded as a vaginal suppository because it achieves a degree of both local as well as systemic effects. Administering a drug by suppository has both advantages and disadvantages. The advantages of using a suppository include it being a viable administration route for patients who are experiencing nausea and vomiting, or who are unconscious or severely debilitated. They can also be used for infants or small children who are not able to swallow tablets or capsules. Another advantage is that suppositories do not have the taste limitations that can occur when giving drugs as oral liquids. The often bitter or unpleasant taste of liquefied drugs can create problems with medication adherence. Additionally, rectal drug administration avoids hepatic first-pass metabolism because the lower and middle rectal veins bypass the liver and enter the general circulation directly. On the other hand, the use of suppositories also has disadvantages. Rectal absorption of a drug can be interrupted by defecation. Also, compared to having the entire length of the GI tract to absorb a drug given orally, there is much less area available for the absorption of a rectally administered drug, since the rectum consists of only the terminal portion of the colon, which is approximately 15 to 20 centimeters in length. There is also less fluid volume in the rectum, with only about 2 to 3 milliliters of fluid for the suppository to dissolve and the drug to be solubilized in. This reduced fluid volume can cause absorption or dissolution problems, such that the absorption of most drugs from rectal suppositories can be erratic and somewhat unpredictable. Lastly, patients do not like using suppositories because they are more difficult and time-consuming to administer, especially when compared to taking a tablet or capsule by mouth. Because of these disadvantages, the use of suppositories is usually done as a last resort. Because of the unpredictable absorption that can occur from suppositories, they should only be compounded extemporaneously when manufactured products are not available. This is especially true when the intended use of the suppository is to deliver a drug for systemic use. As we begin to discuss the formulation of suppositories, it is important to note that there are 5 general classes of suppository base that can be used. Regardless of what the active drug is, we can formulate our suppositories using any type of base. Different suppository bases have different properties, which we will discuss in detail. The 5 different classes of suppository base are listed on this slide. The top 3 are highlighted because they are routinely used by compounding pharmacists, whereas the bottom 2 classes of base are available but are not commonly used, so we will not take the time to discuss them further. Starting at the top, oleaginous bases, of which cocoa butter is the prototype, have historically been the primary base used for compounding suppositories. More recently, a second category of suppository base, called cocoa butter substitutes, and including the commercial product Fattibase, was developed to address some of the difficulties of using traditional cocoa butter. The third category of suppository base is entirely different and is composed of polyethylene glycol, or PEG, base, and includes the commercial product Polybase. We will discuss the unique properties of each of these three bases in a minute. However, before discussing how they differ, I want to mention that all of these categories of suppository base have some desired properties. Thus, I want to make sure you know the common desired properties of a suppository base. First, they are chemically and physically stable under normal conditions of use and storage. They are also non-reactive and compatible with a wide variety of drugs. They are free from objectionable odor and have an aesthetically appealing appearance. These bases are non-toxic, non-sensitizing, and non-irritating to the sensitive tissues they contact. Another physical property they have is called an expansion and contraction characteristic, which means they shrink just enough on cooling so that they will release easily from suppository molds. These suppository bases either melt or dissolve in the intended body orifice to release the drug. The base is non-binding to the drug, so it can be absorbed once the base has melted or dissolved. They must absorb at least a small amount of water to facilitate the melting or dissolution process. The viscosity of the base, when melted, needs to be relatively low to facilitate easy pouring, and yet still be high enough to suspend or maintain the solid drug within the molten base. In summary, there are a variety of desired properties for a suppository base. Of the 5 types listed here, we will discuss the 3 most commonly ones used in more detail. We will begin by discussing the oleaginous bases, of which the classic example is cocoa butter. Cocoa butter is the fat from the seeds of the Theobroma cacao, or chocolate bean. Cocoa butter may be obtained from these beans by either expressing or pumping the oil from the seeds, or by solvent extraction. Cocoa butter is a mellow, yellowish solid with a mild odor and bland taste. Chemically, it is a mixture of triglycerides of saturated and unsaturated fatty acids. Cocoa butter does not contain significant amounts of emulsifier, so it does not absorb much water. Suppositories formed using cocoa butter are solid at room temperature, which is about 25 degrees Celsius or 77 degrees Fahrenheit. However, when cocoa butter suppositories are inserted into the body, they melt at higher body temperatures of 31 to 34 degrees Celsius or 88 to 93 degrees Fahrenheit. Cocoa butter or oleaginous suppository bases have certain advantages and disadvantages. Advantages include being non-irritating to sensitive membrane tissues, as well as having excellent emolliency and soothing properties, which is why cocoa butter is often used for rectal suppositories. Another advantage to cocoa butter is that it is available in a grated form, which eliminates the time-consuming activity of grating or shaving down to small, similarly sized shavings. On the other hand, cocoa butter also has certain disadvantages. The first is that they may give a poor or somewhat erratic release of the drug. Secondly, because of its relatively low melting point, cocoa butter-based suppositories must be stored at either very controlled room temperature or, as most often the case, stored in the refrigerator. The storage temperature should not exceed 25 degrees Celsius. Another big disadvantage from a practical compounding perspective is that cocoa butter can be very easily overheated, and when it is overheated, it may solidify as one of the lower melting point polymorphs. Polymorphs are slightly altered forms of cocoa butter that have reduced melting points, as low as 18 degrees Celsius. The presence of polymorphs in a base causes the suppositories to not set up properly as they cool and solidify. Polymorph suppositories may actually melt at either room temperature or may even liquefy when handled by the patient during the insertion process. One indication of polymorph development is the appearance of the melted cocoa butter itself. When cocoa butter is melted or molten, it should have a slightly opalescent or cloudy appearance. If the molten cocoa butter has turned completely clear with a straw or golden color, but clear, not cloudy, then you have exceeded the melting point and likely created polymorphs. To avoid the formation of polymorphs, cocoa butter must be heated slowly and carefully, often referred to as low and slow. To briefly describe how to melt cocoa butter, begin by grating the base into fine, similarly sized shavings. The consistent size shavings are important because otherwise, as you heat the shavings, the small ones which melt first will overheat and polymorph while waiting for the larger chunks of the base to melt. Consistent size ensures the base melts uniformly. To heat the base slowly, use a water bath, set to about 55 degrees Celsius. Put a glass beaker containing the cocoa butter in the bath and watch it melt. You need to monitor the temperature and not exceed 35 degrees Celsius. Doing so increases the chance of creating polymorphs. The beaker should be removed once the base is molten and has an opalescent, creamy appearance. This process is time-consuming, and the pharmacist must have a lot of patience. Rushing through the heating process often leads to polymorphs and the suppositories that melt in the hand. It is precisely this difficulty in melting cocoa butter and other oleaginous bases that has led to the development of the second type of the suppository base that we will discuss next. The second type of suppository base are the cocoa butter substitutes. A commonly used commercial product is called Fattibase. To avoid confusion with cocoa butter, I will refer to the entire class of cocoa butter substitutes as fatty bases, even though Fattibase itself is a specific commercial product. Remember, cocoa butter is a great suppository base, but has the significant problem of becoming overheated. So instead of extracting cocoa butter from the chocolate bean, fatty bases are produced from a variety of different vegetable oils, such as coconut or palm kernel oil, and then modified by esterification, hydrogenation, and fractionation to obtain products of varying composition and melting temperatures. Fatty bases have all the advantages of cocoa butter, meaning they are non-irritating and melt when inserted into the body, but do not have the difficulties caused by the sensitive melting point temperature range and polymorphism that can occur with cocoa butter. In fact, these products are designed to have a narrow interval between melting and solidification temperatures, which reduces the likelihood of polymorph formation. The two main commercially available cocoa butter substitutes used by pharmacists are Fattibase and Vitepsol. When using either fatty base, they should be heated slowly and evenly, like before, but the base will remain stable, heated up to anywhere from 49 to 54 degrees Celsius. As a reminder, the melting point for cocoa butter that we didn't want to exceed was 35 degrees Celsius. Thus, by using a fatty base, we can heat a little more rapidly and to a slightly higher temperature. The big difference is this fact allows us to use a hot plate instead of a water bath, which is much more convenient. Nevertheless, you can still overheat a fatty base. Monitor the temperature carefully and do not exceed 60 degrees Celsius. From a practical standpoint, this also means that you cannot use microwave ovens to melt fatty base. Lastly, fatty base suppositories release well from molds, but you might consider spraying the mold lightly with a vegetable oil to avoid any issue with the suppository adhering to the mold. The third and final type of suppository base to discuss are composed of polyethylene glycol, abbreviated PEG or PEG. PEG suppository bases are actually composed of blends of various molecular weight polyethylene glycol polymers. One widely used commercial product is called Polybase, which contains a mixture of polyethylene glycols plus an emulsifier polysorbate 80. Because Polybase is the PEG base used in Pharmacy Skills Lab, I often refer to the entire class of PEG bases as Polybase, but please understand that Polybase is a specific commercial product. Polybase, or PEG suppository bases, are formulated so that they do not melt at body temperature. This is very different than either cocoa butter or fatty base, both of which work by melting at body temperature. Polybase does not melt, but rather dissolves in body fluids. That is a big difference between Polybase and other suppository bases. Polybase has certain advantages. Polybase has a melting point of between 50 to 60 degrees Celsius, so it is very heat stable. In fact, Polybase can be heated as high as 100 degrees Celsius without any decomposition of the base. This is very important from a practical standpoint because it means the pharmacist can melt the base quickly using a microwave oven and not worry about overheating the base. Provided that there are sufficient aqueous secretions in the body cavity, Polybase actually provides a more reliable release of the drug from the suppository than does either Fattibase or cocoa butter. Polybase suppositories are very easily made using the fusion method and release well from suppository molds and do not usually require mold lubrication. They also do not require careful storage and can be stored at room temperature. So there are many advantages to using Polybase. However, there are also some important disadvantages. Polybase suppositories can be irritating to the body cavity tissues, and as such are not often used for rectal suppositories because they can potentially stimulate a defecation reflex. This irritation also leads to less patient acceptance, especially when formulating rectal suppositories. Note that the irritation is not a significant problem when used vaginally, and Polybase is very often used for compounding vaginal suppositories. Polybase can interact with polystyrene in plastic prescription bottles. Therefore, they should not be dispensed in plastic containers unless they are individually wrapped in foil. Alternatively, they can be dispensed unwrapped in divided cardboard boxes specially designed for suppositories. This slide discusses how a pharmacist would decide and select the most appropriate suppository base to use in a formulation. There are at least 3 different factors that must be considered. The first would be patient comfort. Cocoa butter and Fattibase are much more comfortable for patients than Polybase, which can be irritating to local tissues. Second, cocoa butter and Fattibase are generally less reactive with incorporated drugs than is Polybase, and therefore have fewer compatibility problems. Third, if the purpose of the suppository is to deliver a drug for systemic absorption, Polybase is considered superior. There are also practical considerations that influence base selection. Preparation is the easiest among using Polybase, and Fattibase is easier than cocoa butter. Nevertheless, the selection of the suppository base will most often be determined by its intended route of administration, as it takes into consideration many of the factors just described. Fattibase and cocoa butter are preferred for rectal suppositories. Despite having less reliable drug release, their less irritating nature and greater drug compatibility makes them the best choice. Typically, Fattibase would be chosen over cocoa butter from a practical standpoint, unless there was some compelling reason to do otherwise. On the other hand, Polybase is preferred for vaginal and urethral suppositories. This is because the vagina and urethra do not have sphincter muscles to prevent leakage, which means that oily material from melted cocoa butter or Fattibase could leak out, which is very undesirable. Moreover, there is generally enough water present to facilitate Polybase dissolution, and from a practical standpoint, Polybase suppositories are quick and easy to prepare. Now we will discuss the 2 different methods used to prepare suppositories, namely hand rolling and fusion. We will start with the hand rolling method, which has been used historically by pharmacists for many years. One advantage to this method is that there is no special equipment or molds required for the hand rolling method. A pill roller is useful, but really any broad-bladed spatula or stiff, flat piece of non-reactive material can be used for rolling suppositories. Cocoa butter is the base used primarily for hand-rolled suppositories, which is an advantage since it is inexpensive, readily available, and issues related to melting cocoa butter do not apply when creating suppositories using the hand-rolling method. Secondly, hand-rolled suppositories do not require any special calculations. In contrast, the fusion method, as we will discuss, has several special calculations which are not required when hand-rolling suppositories. Disadvantages of the hand-rolling method include the fact that preparing and forming hand-rolled suppositories requires experience and good technique. There is a lot of art to the formation of a good hand-rolled suppository. And even when they are well made, hand-rolled suppositories do not have the elegant, consistent appearance of suppositories made by the fusion method. Because they take a lot of skill to produce, do not look as elegant, and take much longer to prepare, most pharmacists use the fusion method. Advantages of the fusion method begin with the fact that they do not require any well-developed physical compounding technique or skill. Secondly, suppositories made by the fusion have an elegant, professional appearance, which is due to the use of a mold. Pouring molten base into a mold allows the mold to shape and form the suppository, giving them a uniform, consistent appearance. Disadvantages of the fusion method include needing to purchase specialized suppository molds, which can be expensive. Another legitimate concern is that you have to use caution when incorporating drugs that are sensitive to heat, since you will be adding the drug to molten suppository base, and the heat from that base can affect the drug. Another disadvantage is that while active ingredients are dosed and measured by weight, suppositories using the fusion method are compounded by volume. By this I mean the molten base is poured into the mold cavity, which has a fixed volume. So while suppositories using the same mold may have the same size and shape, they may weigh different amounts due to differences in the density of the base. We will discuss this issue in much more detail, but I bring it up now because using the fusion method requires the pharmacist to perform specialized calculations, mold calibration, and procedures such as the double casting method. In summary, while the fusion method allows the creation of elegant and uniform suppositories with little physical training or skill, it requires the pharmacist to be well versed in performing multiple calculations needed to ensure that the suppository contains the correct amount of the active ingredient. The fusion method trades physical dexterity for mental dexterity. When using the fusion method, we are adding our drug into molten base and then pouring that liquid mixture into a mold to shape and form our final suppository. Therefore, the molds used in this method are very important. Suppository molds are available from many different vendors of compounding supplies and in a wide variety of shapes and made from different materials. Suppository molds may be either disposable, meaning single use only, or be reusable. Molds are available with various cavity capacities ranging from less than 1 milliliter to more than 2 milliliters in volume. Molds are commonly available made from 3 different materials, as shown in this picture. On the top are plastic disposable molds, which are often called shells. These shells are made from really thin plastic and connected in long strips that can be cut into the number of cavities desired. Plastic shells are disposable, single-use only mold that does not require lubrication. They are much less expensive to use than other molds. The problem with disposable molds is that the plastic is very, very soft, and if you pour molten base that is too hot, the heat will shrink the mold and actually make it implode, ruining the suppository. Moreover, the soft plastic molds can become easily dented and deformed while handling them, and if the shell is already dented, then the suppository it forms will also be dented and deformed. The mold has space at the top for overfilling that must be trimmed off prior to dispensing. Therefore, the suppository shell should be removed and the suppository trimmed and then either wrapped in foil or placed in a suppository box for dispensing. However, some pharmacists use a very sharp blade to cut off the overfill while the suppository is still wrapped, allowing them to dispense the product without removing them from the plastic shell. The second type of mold is shown in the middle and is a metal mold, usually made from aluminum, but occasionally made from brass. As you can see in this picture, metal molds separate into 2 halves and are held together by screws with wing nuts. Metal molds often require the use of lubrication and with either a vegetable oil spray or a light coating of mineral oil to facilitate the removal of the final suppository. Advantages of metal molds include that they create aesthetic, uniform-appearing suppositories and are available in a variety of different cavity sizes and volumes. For example, the mold in this picture has 12 cavities that each have 1 milliliter in volume. Different molds would have different numbers of cavities, a different volume for the cavity, and be shaped differently depending on whether you wanted to create a rectal or vaginal suppository. You can buy molds that stack together and form a mold that has 1,000 cavities. Another consideration regarding metal molds is their cost. Metal molds are an investment. By that I mean they are expensive to purchase initially, but can last forever. The third type of suppository mold, shown on the bottom of this picture, are the flexible rubber molds, sometimes called strips. These molds are growing in popularity because they are disposable and no lubrication or wrapping is required. The base is poured into the cavities, and once cooled and the excess is trimmed off, the mold is placed into a sleeve that is designated for that purpose and is then labeled and dispensed. Patients like these rubber molds as they can simply stretch them a little bit and the suppository is easily removed. Rubber molds are less expensive to heat and do not dent or deform as easily as plastic molds, but are more expensive to use than the shells. Nevertheless, their use is growing and becoming more common. The fusion method has the advantage that it does not require much technical skill to create nice, uniformly shaped suppositories. The disadvantage is that it requires the pharmacist to understand specialized calculations related to volume and density to ensure the final product has the correct dose. We will now discuss those calculations. First, when using the fusion method, we will weigh a certain amount of our suppository base. We will also weigh a certain amount of our active ingredient powder. Next, the base will be liquefied, and then our active drug will be added and dispersed throughout the molten base. This mixture is then poured into the suppository mold cavities. We do not pour in a certain weight, we fill the mold up to its cavity limit. That means that the suppository, or our dosage unit we are preparing, is actually created by volume, not by weight. There are three factors that will determine the final weight of the drug in a suppository prepared this way. The first factor is the weight per weight concentration of the active ingredient in the base material. The second factor is the volume of mixture contained in each mold cavity. The third factor is the density of the molten mixture. Different suppository bases have different densities. Let us use an example to illustrate these factors. We are using an aluminum suppository mold that has a 2 milliliter cavity. If we pour water into the cavity, since water has a density of 1 gram per milliliter, the amount of water in the cavity would weigh 2 grams because 1 gram per milliliter times 2 milliliters equals 2 grams. Now, we do not make suppositories out of water because that does not solidify. So next we use cocoa butter, which has a density of 0.86 grams per milliliter. We melt cocoa butter and completely fill the 2 milliliter cavity. Once the cocoa butter cools and solidifies, we remove and weigh it. It would weigh 1.72 grams because multiplying its density of 0.86 grams per mil times 2 milliliters equals 1.72 grams. Using that same mold, if we chose to melt PEG 400 and pour it into the cavity, it would weigh 2.25 grams after it's cooled because its density is 1.125 grams per mil times 2 milliliters equals the 2.25 grams. In summary, the same suppository mold, depending on the base used, can produce suppositories that weigh anywhere from 1.72 grams all the way up to 2.25 grams. The difference in weight being due to the difference in density of the base being used. Therefore, it is absolutely necessary to calibrate every suppository mold with the specific base to be compounded. Mold calibration is straightforward. Melt some of the base you are interested in. Pour 5 suppositories into the mold to be calibrated. Let them cool. When the base is solidified, remove the suppositories and trim them like you would be dispensing to a patient, and then weigh each of the 5 suppositories and determine an average weight. By doing this, you know the average weight of a blank, base-only suppository for that mold. This base-only mold calibration weight is now used with the density displacement calculations discussed next. We've just discussed how bases with different densities can produce suppositories with different weights from the same mold. We must now add to that concept by understanding that our suppositories are not only composed of base, but also include a certain amount of active ingredient powder. That amount of active drug powder will displace a certain amount of suppository base. Since the volume of the mold cavity is fixed, then if part of the volume is occupied by drug powder, then it cannot also be occupied by molten suppository base. Therefore, we must account for the differences in density between the active drug powder and the suppository base. If we were perchance had a drug that had the same exact density as the suppository base, then the weight of powder would displace an equal weight of suppository base. However, if the density of the drug is greater than the base, the weight of drug powder will displace a proportionally smaller weight of base. Conversely, if the drug powder is less dense than the suppository base, then it will displace a larger weight of base. To account for differences in density between the active drug powder and the suppository base, we must determine a density displacement factor, abbreviated as DDF. The definition of a DDF is the weight of drug powder in grams that will displace exactly 1 gram of base. Note, a DDF is given for a specific drug in a specific suppository base. Different drugs have different DDFs in the same base. Moreover, the same drug might have different DDFs for different suppository bases. An example. We want to compound a rectal suppository containing 0.5 grams each of boric acid in cocoa butter base. Boric acid is available as a bulk powder, and the DDF for boric acid in cocoa butter is 1.5, which means that 1.5 grams of boric acid will displace exactly 1 gram of cocoa butter. We can set up the ratio of 1.5 grams boric acid over 1 gram of cocoa butter equal to 0.5 grams of boric acid over X grams of cocoa butter. Solving for X, we determine that 0.5 grams of boric acid will actually displace only 0.3 grams of cocoa butter. DDF calculations become a little more difficult when the source of active ingredient powder is from a commercially prepared tablet or capsule, because these products often contain excipients as well as drug. The excipients in the powder may have a different DDF than the active ingredient, and so a second displacement calculation based on the amount of excipient present in the powder is also required. An important question to ask is, how do you know what the DDF is for your drug in the base to be used? It is possible that that information has already been published. There are tables listing DDF for various drugs in certain bases, like the one on the next slide for cocoa butter obtained from Remington's. The pharmacist could also look for a published formulation that gives a DDF. However, in many cases of extemporaneous compounding, you may not be able to find a reference that gives a DDF for your drug in your desired suppository base. So what happens if you cannot simply look up the DDF? There are two methods used to actually determine a DDF for any drug in any suppository base. They are the double casting method and the Paddock method of DDF determination. The next slides will outline these methods briefly and are commonly used to determine an unknown DDF. Please note that once a pharmacist has determined a DDF experimentally, the procedure does not need to be repeated, meaning once that it's been determined, the DDF can simply be used in the calculations for subsequent preparations of the same drug in that same base. As mentioned on the previous slide, various references, such as Remington's, give examples of density displacement factors for various drugs in a specific suppository base. For example, this table lists the DDF for various drugs in cocoa butter. Thus, if you were preparing any of these drugs in a cocoa butter-based suppositories, you could use the DDF to calculate the amount of base displaced by the active ingredient. You would not need to perform either the double casting or Paddock method of DDF determination because you already know the DDF. However, looking at this list, you will notice it does not contain many commonly used drugs. So more often than not, you must be able to determine a DDF experimentally because it is not readily available in the literature. If the DDF is not published in the literature for a drug in a specific suppository base, the pharmacist could use either the double casting method or Paddock method for DDF determination. In the Pharmacy Skills Lab, we have you perform the double casting technique, since it is an established technique with a relatively straightforward procedure and requires less math than the newer Paddock method. The procedure for the double casting method is outlined in this slide, and I will describe each step briefly in the subsequent slides, and then perform the calculations using an example. The first step in the double casting method is to calibrate your mold for the suppository base to be used, meaning you need to know the average weight of a trimmed suppository using base only with no active drug. Next, take the total weight of active drug needed for all suppositories to be prepared and add that powder to an inadequate amount of molten suppository base. An inadequate amount of base means 1/3 to 1/2 the total amount estimated to fill the cavities completely, based on the mold calibration. Thus, all of the drug should be added to only a fraction of the base, once that base has been liquefied. Thoroughly mix the drug and base until evenly mixed. Next, partially fill each mold cavity for all suppositories. This is an important step to understand. If you are making 10 suppositories, then you must partially fill all 10 suppositories. It does not matter how much is in each cavity. Each cavity can have a different volume at this point. However, they must all have some amount of the drug and base mixture, and all must be only partially filled, meaning none of the cavities should be filled to the top. This is why only a fraction of the total amount of base was used at this point. Now, melt some additional blank suppository base. The amount should be more than enough to completely fill the cavities. Use the molten base first to rinse the initial beaker that contained the drug, and pour the rinsings among the cavities, always being sure to still underfill each cavity. When no more drug can be rinsed from the initial beaker, use the blank molten base to completely fill and then overfill each cavity, as shown in the picture on the left. Because suppository base contracts as it cools, it is very important to overfill each cavity with blank molten base. So at this point, each cavity is partially filled with drug, and the remainder of the volume filled with blank base. Once the base has cooled and solidified, each suppository should be trimmed and removed from the mold. The picture on the bottom right of this slide shows how each suppository, once trimmed, contains a portion of the drug at the suppository tip and a portion containing the pure base on top. Now, use the digital scale and weigh all of the suppositories, and then divide that weight by the number of suppositories to determine the average suppository weight. This step is very important. You must determine the average suppository weight at this point before proceeding with the next step. After weighing and calculating the average suppository weight, place all of the trimmed suppositories into a glass beaker and remelt them, as shown in the picture on the left. After all of the suppositories have remelted and become molten once again, be sure and mix and redistribute the drug evenly throughout the mixture. Because each initial suppository had a different amount of drug, it is very important to stir and mix the drug and base thoroughly as it melts. Next, re-pour the homogeneously mixed molten base into mold cavities, being sure to completely fill and then overfill each cavity. Remember, this time you are completely filling, not partially filling each cavity. This step is shown in the middle picture. Allow the base time to cool and solidify. Once again, trim and remove each suppository. These suppositories can be dispensed to the patient because each contains the correct amount of drug. This is because the second melting contained suppositories with all of the active drug, due to the initial underfilling, and the exact amount of base needed, since they were filled and trimmed with blank base. The second melting and careful mixing redistributed the drug throughout the mixture, ensuring the correct concentration before they were re-poured into the mold the second time. Also, at this point, you have all of the information you need to calculate the DDF, which includes the average weight of a blank suppository, the average weight of a drug-containing suppository, and the amount of drug in each suppository. Calculating the DDF now will permit you to avoid having to use the double displacement method in the future. However, the calculations are best explained using a specific example, which will be discussed on the next slides. For example, a prescription calls for 0.3 grams of drug Z in a Polybase vaginal suppository. We check the literature, but cannot find a published DDF for drug Z in Polybase. Our first step is determine the weight of a blank, pure Polybase suppository using our aluminum mold. So we pour 6 blank suppositories and determine their average weight to be 2 grams. We then begin the double casting technique as previously described, pouring 6 suppositories. The total amount of drug needed to prepare 6 suppositories, each containing 0.3 grams, is 1.8 grams of drug Z. Upon completing the double casting technique, we find that the average weight of a medicated suppository is 2.1 grams. Next, to determine the weight of base only in the medicated suppository, subtract from the weight of the medicated suppository, which was 2.1 grams, the amount of drug per suppository, which was 0.3 grams, to determine that the weight of base in that suppository was 1.8 grams. Now, calculate the weight of polybase displaced by taking the weight of the blank, pure base only suppository, which was 2 grams, and subtract the weight of the base present in the medicated suppository, which was 1.8 grams. And note that the 0.2 grams of polybase, this difference, was displaced by the drug Z. The last step is to actually calculate the DDF. Recall that a DDF is the weight of drug displaced per gram of base. To calculate the DDF, take the weight of drug Z in each suppository, which was 0.3 grams, and divide it by the weight of polybase that was displaced, which was 0.2 grams. The result is 1.5, which is the DDF for drug Z in polybase. The Paddock method, published by Paddock Laboratories, is a second method for determining a density displacement factor for a drug in a specific suppository base. The method is outlined step by step on this slide, but I will not take the time to cover it in detail. It suffices to say that it is an alternative to the double casting method that requires a little more math and numeric manipulation, as it makes use of a replacement factor. Once this replacement factor is determined experimentally, it can be applied to all subsequent formulations of that drug and specific base. The take-home point is that either the Paddock or double casting method can be used to formulate suppositories when the density displacement factor for a drug in a specific base is not known. In the Pharmacy Skills Lab, we expect students to perform the double casting method and to be able to calculate a DDF. We have spent a lot of time describing how to calculate and determine density displacement factors. Now we will use an example to illustrate how to use a DDF, whether determined experimentally or already published in the literature, to extemporaneously compound suppositories. We will first perform the calculations and then describe the actual compounding procedure using the fusion method. The prescription calls for a diphenhydramine 12.5 milligram rectal suppository and to dispense 6. Our source of diphenhydramine is commercially available 50 milligram capsules. Remember, commercially prepared capsules often contain not only active drug, but also excipients such as binders or fillers. Thus, the powder contents of a single diphenhydramine capsule will provide both 50 milligrams of diphenhydramine as well as a certain weight of excipient. Next, notice that the prescription does not direct us to use any specific suppository base, so we must choose a base. Since we are making rectal suppositories, we could choose to use either an oleaginous base, such as cocoa butter, or a cocoa butter substitute, such as Fattibase. Practically speaking, most pharmacists would probably choose to use the Fattibase because it has less possibility of forming polymorphs if overheated. So in this example, we choose to use Fattibase. A second choice to make regards which type of mold to use. For this example, we will use plastic shell molds, which we have already calibrated for Fattibase and which is 1.8 grams, meaning a blank, Fattibase only suppository weighs 1.8 grams using our plastic mold. Another consideration that we have not already discussed pertains to the number of suppositories to prepare. We actually have to calculate and compound for excess because there is always loss of product that occurs during the procedure. Thus, base calculations on the preparation of at least 2 extra suppositories. The suggestion of 2 extra applies to even experienced or skilled compounders. Often in Pharmacy Skills Lab, we recommend beginning students prepare for at least 4 extra, just to ensure that they have enough to dispense the prescribed amount. However, for this example, we will base our calculations on the preparation of 2 extra or 8 total suppositories. Next, we need to know the density displacement factors. Fortunately, the DDF for diphenhydramine in Fattibase has been published and is 0.8. However, our commercial capsules not only contain diphenhydramine but also excipient. In this case, the DDF for excipients in Fattibase is 1. We now have all the information needed to begin our calculations. Start by multiplying the total number of suppositories to prepare, which is 8, by the mold calibration of 1.8 grams, which equals 14.4 grams and represents the total weight of 8 suppositories using our mold. Next, determine the total amount of diphenhydramine needed, by multiplying 8 suppositories by 12.5 milligrams per suppository, which equals 100 milligram or 0.1 when expressed in grams. Next, determine the number of commercial capsules to use by dividing the amount we need, which is 100 milligrams, by the amount of diphenhydramine per capsule, which is 50, to determine that we need to use the contents of exactly 2 capsules. However, because these capsules also contain excipients, we must weigh the contents of the 2 capsules. We pull the 2 parts of the capsule shell apart and carefully remove all of the powder inside into a weighing boat for both capsules. We determine the weight of powder from both capsules to be 380 milligrams. Next, determine the amount of excipient in the capsule powder by taking the total weight of 380 milligrams and subtracting the amount of diphenhydramine, which is 100 milligrams, to find that there will be 280 milligrams, or 0.28 grams of excipient in our formulation. Next, begin the process of determining how much fatty base will be displaced by both the diphenhydramine and the excipients. Start with diphenhydramine. Set up a proportion using its DDF as 0.8 grams of diphenhydramine over 1 gram of fatty base. Set that equal to 0.1 grams of diphenhydramine over X. Solving for X, we find that 0.1 grams of diphenhydramine will actually displace 0.125 grams of fatty base. Next, perform the same calculation for the excipients by setting up the ratio of 1 gram of excipients over 1 gram of fatty base equal to 0.28 grams of excipients over X. Solving for X, we find that our excipients will displace an equal amount of 0.28 grams of fatty base. Now we can solve for the amount of fatty base required to prepare our 8 suppositories. Begin with the total weight needed, which was 14.4 grams, and subtract the amount of fatty base displaced by the diphenhydramine, which was 0.125 grams, and also subtract the amount displaced by the excipients, which was 0.28 grams, which equals a total of 14 grams of fatty base. At this point, it is very important that you understand that we did not subtract the actual weight of diphenhydramine or excipient, but rather the weight of fatty base displaced by those ingredients. Our calculations are now complete. To summarize, before discussing the compounding procedure, we will use the powder contents of 2 diphenhydramine capsules with 14 grams of fatty base in the preparation of 8 suppositories. Now that we have finished our calculations, we can discuss the fusion procedure used to actually prepare the suppositories. Begin by preparing the mold. In this example, we are using plastic disposable suppository shells, so we would count out 8 shells, cut them off the roll, inspect them, and discard any and replace any with dents or creases in the plastic, and obtain a holder that stands these shells upright. This is shown in the picture on the left. Please note that had we been using an aluminum mold, we would need to lubricate it with a vegetable oil spray or mineral oil. However, lubrication is not required for our disposable plastic shells. Next, obtain the diphenhydramine powder by opening and placing the powder contents of 2 capsules into a weighing boat, as shown in the middle picture. Next, prepare the fatty base before weighing. Do this by grating an excess amount of fatty base into small, consistently sized shavings, as shown in the picture on the right. Remember, having small shavings allows the fatty base to melt evenly and helps avoid overheating. When enough fatty base has been grated, weigh 14 grams of the shavings and transfer into a glass beaker. Next, use a hot plate on a medium-low setting and cautiously melt the fatty base. Remember, while fatty base is less sensitive to polymorphs than cocoa butter, it can still be overheated and should not be melted in a microwave oven. Once the base has completely melted and turned to liquid, keep the beaker on the plate, but turn off the heat and add a stirring bar and turn the stirring knob to between medium and fast to get a nice stirring vortex in the molten base. Begin adding the active drug powder by slowly sifting it into the vortex of the swirling molten base as shown in the picture on the left. The slow sifting and rapid stirring is necessary to prevent the powder from clumping as we add it to the liquefied base. Continue to add by sifting all of the diphenhydramine powder and ensure that it is evenly dispersed and is homogeneously mixed throughout the base. Next, turn off the stirring knob, remove the beaker from the hot plate, and retrieve the magnetic stir bar using a metal spatula. And continue to stir the mixture using a glass stirring rod as it cools. Remember, the plastic shells are very thin and sensitive to heat. If we pour the mixture too soon, the shells could shrink and implode, ruining the suppository. Continue stirring and touching to feel the bottom of the glass beaker. When the bottom of the beaker can be left on your palm without discomfort, meaning it is warm but not hot enough to hurt, the base is cool enough to pour. Next, carefully begin to pour the base into the shells. Plastic shells need to be filled to the top. Remember, molds typically have to be overfilled to allow for the contraction that occurs as the base cools. However, plastic suppository shells provide extra space at the top to allow for contraction, so they need only be filled to the top. Next, allow the suppositories to cool and solidify. Most suppository bases are solid and can be handled after cooling for 30 minutes at room temperature. Cooling can be accelerated by placing them in a refrigerator, but it is not recommended as the quicker they solidify, the greater the degree of contraction that occurs, as well as making the suppositories excessively hard, brittle, and more difficult to trim to the correct size. Once the suppositories have solidified, they should be carefully removed from their shells, as shown in the middle picture, and trimmed to the correct length using a sharp knife or a razor blade, and then either wrapped in foil or placed in a divided suppository cardboard box, as shown in the picture on the right. The product is now ready to be labeled and dispensed to the patient. Now we will discuss preparation guidelines for compounding suppositories. The first guideline to discuss is quality assurance. To ensure the quality of the final product, the pharmacist should document in the compounding record the following: average or individual suppository weight, shape or physical appearance, color, and texture of the suppository. The second preparation guideline is beyond use dating. Generally speaking, most suppositories are stable both physically and chemically if stored under appropriate conditions. This is in part due to suppositories having little or no water, since water can accelerate drug degradation and promote microbial growth. Nevertheless, always look for published stability data for any formulation. However, in the absence of stability information, the USP Chapter 795 General Recommendations for Non-Aqueous Formulations states that the beyond use date is not later than the time remaining until the earliest expiration date of any active ingredient, or in 90 days, meaning 3 months, whichever is earlier. The third preparation guideline is about the amount to prepare. USP Chapter 795 states for suppositories to prepare an excess amount of the total formulation to allow the prescribed quantity to be accurately dispensed. As described previously, loss of product is common when compounding suppositories. Molten suppository base is viscous and tends to adhere to glass beakers, spatulas, and stirring rods. Moreover, as the molten base cools, it thickens to the point of becoming solid again. If the compounder works too slowly, much of the product becomes irretrievably stuck to the glassware. To minimize loss, avoid using large glass beakers with tall sides, and work as quickly and efficiently as possible once the base is melted, and until it has been poured into the molds. Because of this loss, always calculate and prepare at least 2 extra suppositories. Actually, as mentioned in Pharmacy Skills Lab, we often have students prepare 4 extra suppositories to ensure they actually have enough to dispense the prescribed quantity. The last preparation guideline to discuss is product labeling. The suppository should be described with its drug name, the weight of drug per suppository, and an indication of the route of administration. An example might read, morphine sulfate 2.5 milligram rectal suppository. The SIG, or instructions for the patient, must also be explicit in terms of how and where to insert the suppository. If the suppository is wrapped in foil, then the instructions should indicate to unwrap it. Moistening the tip of the suppository prior to administration is also sometimes indicated. Also, the route of administration must again be clearly stated. An example might read, unwrap and insert 1 suppository rectally at bedtime. There may also be auxiliary labels that should be attached to the compounded suppositories. Most important are labels that warn about product storage. For example, it is extremely important that cocoa butter or Fattibase suppositories be kept in the refrigerator to avoid the possibility of melting prior to administration. Moreover, it was equally important that Polybase suppositories be labeled as stored room temperature, do not refrigerate. It is not a problem due to the cold temperature, but rather because the air in most refrigerators is very humid, and the moisture could interact with the polybase and start to dissolve it. Also, as suppositories are often dispensed in non-child resistant packaging, be sure and attach a label that says to keep out of the reach of children.